to this edition of the Idec Cafe. And this is going to be purely an obesity symposium. And we have two stalwarts with us, and we're going to be dealing with topics which are beyond lifestyle management. We all know that lifestyle management and lifestyle modification is the cornerstone of therapy of obesity throughout the journey of obesity of a particular person. However, that may not be sufficient. And that is the reason that we have thought of talking about beyond lifestyle modification in this symposium. So the two modalities of treatment beyond lifestyle modification are pharmacotherapy and bariatric surgery. And to this end, we have two very good speakers to take us through these two different aspects of obesity therapy. So let's begin with our first speaker. And we have Dr. Carolyn Apovian, the co-director for the Center for Weight Management and Wellness in Brigham and Women's Hospital. She's also a professor of medicine, Harvard Medical School, past president of the Obesity Society in the year 2018. And Dr. Carolyn will take us through an update on anti-obesity medications with a word on lifestyle weight loss as well. So over to you, Dr. Carolyn. We are very, very excited to hear you.
Thank you so much, Dr. Deshpande. Can you hear me and can you see my slides?
Yes.
Wonderful. All right, so I'm very pleased to talk to you today about anti-obesity medications. So let's get going. At least in the United States, the prevalence of obesity...
Recording in progress.
Dr. Carolyn, you've gone on mute. Dr. Carolyn, you are on mute.
Okay, thank you. Can you hear me now?
Yes, we can.
All right. So the prevalence of obesity in the United States has gone from about 10% in the 60s to today's over 40% of Americans have a BMI over 30. It's almost half of the population. There doesn't seem to be a halting of the increase in prevalence, and so we need to do something about it. If you look at the trends in both overweight and obesity, so overweight is defined as a BMI over 25, you can see that back in the 1960s, the prevalence of overweight was fairly high, and obesity, and more importantly, severe obesity, was low. Obesity prevalence was a little bit over 10% or so, and severe obesity was very, very rare. And now we see that the prevalence of overweight hasn't changed. It's still about 30% of the population, but obesity now over 40%, and severe obesity, defined as a BMI over 40, for which bariatric surgery is indicated, is almost 10%. So what happened is that our genes don't work that quickly. We certainly know that in the presence of this environment, the genes that determine storage of body fat and the ability to store fat can help exacerbate the obesity. But our genes haven't changed since the 60s. And so we, assume that it is the environment that has changed. And what's changed in the environment is the presence of ultra-processed foods. That's what's changed in the environment. Why do we want to treat this condition? First of all, obesity is a disease, and secondly, it causes other complications that then cause death. And it accounts for 4 million deaths worldwide per year. And it causes heart disease and diabetes. So we need to treat it And this treatment needs to be immediate, actually. And so what are the treatments that we have available? Well, we're going to talk about behavior. What kind of weight loss and maintenance of the weight loss can a multi-component behavioral intervention help produce? About 2 to 5% weight loss. Now, if you have a patient who weighs 300 pounds, that's going to be up to 15 pounds. And, these patients need to lose more than that. Intensive prescriptive nutritional interventions, very low calorie diets, and the protein sparing modified fast can help elicit a 5 to 10% weight loss. Drugs, which we're going to talk about, can now elicit up to 20%. We have endoscopic procedures, the endoscopic sleeve gastrectomy, where you suture a piece of the stomach closed. That can help elicit a 10 to 20% weight loss. And the only treatment that can produce up to a 40% weight loss is indeed bariatric surgery, which will be talked about in the next talk right after mine. So now, having said that, very few patients are treated for their obesity in the United States with a drug. There are many reasons for that, but if you compare the medical treatment for obesity versus the medical treatment for diabetes, in this country, as I said, 45% of Americans have obesity, and about 14% of Americans have diabetes caused by obesity. Diabetes is caused by obesity. Type 2 diabetes. How many patients are treated with at least one drug for their diabetes? About 85%, right here, okay? And when you think about obesity, only 2% of the population that has obesity are treated with a drug. If you said this about any other condition, hypertension, cardiovascular disease, you would say that we're practicing negligence and malpractice. But because obesity, there are no guidelines saying you must treat obesity. Patients who walk into their doctor's office, primary care, they can have a BMI of 40 and above, and the doctor doesn't have to address it. That's the problem. So we developed guidelines. I was the first author, the chair of this guideline that was published in 2015 in the Journal of Endocrinology and JCEM, the Journal of Clinical Endocrinology and Metabolism. And we gave guidelines for how to treat obesity and how to not provide patients drugs that cause obesity, that cause weight gain. What conditions prompts a doctor to give your patient a medication? And these should be prescriptive, but they're not yet. They're just suggestive. So anybody with a BMI over 30 is a candidate for an anti-obesity agent, and over 27 with at least one comorbidity or complication. What are these complications? Reflux, arthritis, back pain, metabolic syndrome, diabetes, heart disease, all of that. How does the FDA approve an anti-obesity drug for use in the United States? The drug must induce a significant placebo-adjusted weight loss of at least 5% weight loss, or at least 35% of patients on the intervention arm should achieve a 5% weight loss, which must be at least twice that induced by placebo. In addition to those two criteria, you must either or. The medication should show improvement in blood pressure, lipids, and glycemic control, not the opposite. So, several drugs were approved by the FDA in 2013 and 2014, and then semaglutide, which has gotten quite a bit of attention in the media now, was approved in 2021. It's indicated for weight management in patients with a BMI over 30 or over 27 with at least one ailment. It works by mimicking GLP-1, which is a naturally occurring gut hormone. Therefore, it's the first drug for obesity, which is an analog of a naturally occurring gut hormone, which regulates appetite and food intake. So, patients should see this as an injectable vitamin, all right, because it's a naturally occurring hormone. The dosing is increased gradually to reduce the nausea and vomiting, constipation and fatigue that you can get if you suddenly try to give semaglutide to a patient at a dose of 1.7 or 2.4. They are going to get very nauseous. Now, what about the efficacy? This has really doubled the weight loss that you were able to see with the other drugs. So this is why it's such a game changer, as it has been called in the media. The STEP trials, step 1 looked at obesity alone, and with obesity alone, you get a 15% body weight change. Unbelievable. Step 2, in diabetes, you get a almost 10% weight loss. Step 3, weight management with intensive behavior. You see that the weight loss is enhanced by an intensive behavioral program instead of a normal behavioral program or light. And step 4 was looking at the second year with how, if you keep the patient on the drug, do you get weight maintenance? And you certainly do, especially compared to the placebo group, which lost the weight but then got placebo. So they got, the first year they got the semaglutide, and the second year they got placebo. They gained weight. Of course. Why would you even have to do this with a drug for hypertension? You know already that if you take the patient off the drug, the blood pressure is going to come back. Why do you have to do this with obesity? Because people don't realize it's a disease. So we have to show them that it's a disease. All right. Now, here I am comparing the two new drugs, semaglutide and tirzepatide, with the other drugs. So the best drug in the past was Fentope, combination of phentermine and topiramate. We got almost 10% weight loss. Liraglutide, which is Saxenda, phentermine alone, naltrexone, bupropion, or Contrave, and Orlistat, or Zeneca. You see the increase in weight loss with semaglutide, which is followed here by tirzepatide, which was approved as Mounjaro for diabetes and soon to be approved for obesity in the next few months, we hope, giving you an 18% weight loss. Now, this is placebo subtracted. So you add the placebo weight loss, and it's going to be 22%, which, guess what, is almost like a sleeve gastrectomy. Here is the weight loss that was published in the New England Journal with patients with obesity, 15 milligram dose, 21% weight loss, which is incredible. Okay? We're changing the way obesity is treated in this country. All right, now, here is a slide showing all of the FDA 1 and 2 year studies that were presented to the FDA before these drugs were approved, starting with Orlistat, with the Zendos trial. Here's Fentope, which is Qsymia, the CORE studies, Contrave, the SCALE trials for Saxenda, the GLOW study for the device Plenity, and then semaglutide or Wegovy and tirzepatide or Mounjaro. As you can see, this is the categorical weight losses compared to placebo. Most patients on the intervention arm are losing at least 5%, and the biggest percentages are with the latter two agents, which are GLP-1 hormones, which is why we're so excited. Most patients on these newer agents are going to lose weight. Now, here is where we compare the drugs, the anti-obesity agents, to the sleeve gastrectomy. Now, the sleeve gastrectomy produces a 25% average weight loss at the end of a year. The Roux-en-Y gastric bypass will produce 33% weight loss, but that isn't as utilized as much as now that the sleeve gastrectomy has come to its heyday, because the sleeve gastrectomy is an easier procedure and doesn't bypass any of the intestine. Patients like that better, even though the Roux-en-Y gastric bypass is going to give you more weight loss. But if you compare the sleeve gastrectomy now to these newer agents, you see that we're not too far off, especially with tirzepatide at its highest dose, 50 milligrams. You're basically getting a surgical weight loss with one drug, which is a combination of two gut hormones, GLP-1 and GIP. This is why this is such a game changer. Now, if you combine surgery with medication, you get even better weight loss. Now, we haven't done this yet with tirzepatide. We've done a bit of it with semaglutide, but we need longer term studies showing what does semaglutide in combination with the sleeve gastrectomy. We're probably not going to be able to produce better weight loss, but we're going to be able to produce maintenance of the weight loss that you see with surgery. So here we have a case of a patient who had a weight of 371 pounds, diet and exercise, as you see, can produce a 10% weight loss, but then there's weight regain. Of course, there's weight regain with diet and exercise. It always happens. We're not changing the body's defense of the weight in this environment. So the patients regain weight. They get placed on medications here, metformin plus Fentope, lost weight again, regained, got the laparoscopic adjustable band, which we don't do anymore because it's just a band that's placed around the stomach, doesn't change any gut hormones. So obviously the patient's going to lose weight, but they're going to start to regain. And then the patient was placed back on metformin Fentope, and with the combination of the laparoscopic band plus 3 medications, the total weight loss is 100 pounds. Of course, there's going to be weight regain. You don't lose sight of these patients. You follow them every 3 months forever, but there's weight loss and maintenance. Now, even though these drugs are effective, as I said before, they're rarely prescribed. Why? Nearly 50% of adults fit criteria for the use of anti-obesity pharmacotherapy. It's a disease. It causes morbidity and mortality, but less than 2% of patients eligible received an anti-obesity medication in the last year. More patients with higher BMIs, but look at this, 3.4%. That's ridiculous. Why is that? Because people don't realize it's a disease. They still think it's a matter of their willpower. Patients and providers don't understand. And then in the end, if you don't get insurance coverage of these medications, they're expensive. So Okay, why is obesity a disease? Here is a schematic showing you the arcuate nucleus and the hypothalamus of two sets of neurons. If you activate POMC-CART, you get satiety. And look at all the afferents they get. GLP-1, leptin, insulin, ghrelin, PYY. Ghrelin deactivates POMC and activates the other side, which causes hunger. You get these afferents from the gut and from fat tissue, telling the brain, do you have enough fat to live? Fat storage. And it's a very tightly controlled system. If the afferents say, there's not enough fat, the patient, we're hungry, then you're going to reduce the activation of satiety, you're going to get hunger, and you're going to get decrease in total energy expenditure, okay, upstream, until the patient regains the weight. And then the environment is also playing a role here somehow. The brain senses that the environment is full of high calorie food, and you still have the genes eons ago that said when you see a deer, you eat the whole thing because you don't know when you're going to see another one. Same genes are effective today. So our genes haven't gotten to 2023 where we have too much food in the environment and we're storing a lot of body fat, and that's what's happening. Where do our drugs work? They work in the same area, in that arcuate nucleus, to activate the satiety center, but some of them also work in the reward center, i.e. naltrexone bupropion. Naltrexone is an anti-addiction agent, and also semaglutide and liraglutide also have reward pathway. And what does this do? It makes you not want to go for the chocolate and the reward and the sweets. It makes you instead prefer healthy food. Amazingly so, but that's what it does. GLP-1R agonism has changed the face of how we treat obesity. It has effects in the brain, as I said, decreasing reward, food intake, palatability of sweets. But it also works in the intestine, decreases gastric emptying and gastrointestinal motility. So the food stays in there longer and continues to get to elicit satiety. It works in the liver to reduce fat in the liver, in the pancreas, and in the muscle. All right. So there are multiple agonisms that GLP-1 enhances that makes it far and away much better than the older agents that just reduce hunger in the brain. I don't have to do this because you understand that obesity is a disease, but long-term ongoing therapy is needed because if you stop the drug, the weight comes back. You can superimpose what happens to diabetes and hypertension if you stop the medications. Your blood pressure goes back up and your blood sugar goes back up. Okay, so once, and we even studied this. Here is the findings when you lose weight with semaglutide, and then the second year, give the patient placebo, the patient gains 7% back. We proved it. You have to stay on the drug to keep the weight off. If you don't lose 5% of your body weight in 3 months, what you need to do is to add another medication or switch it out by something that works, because even though 91% and 86% of patients lost at least 5%, there's still, even with tirzepatide, there's still that 9% that are not responsive to that drug, so you need to add something to that. Now we're going to switch off and talk about lifestyle. Here is what you can get with lifestyle alone. With a very low calorie diet, you can get a lot of weight loss. But once you stop that very low calorie diet, you're going to gain it back. With intensive behavioral therapy, you're going to get 4 to 6%. With a light lifestyle intervention, 3 to 5% weight loss. Again, this is not enough for most people. Why do we use VLCDs? 10% weight loss prior to fertility treatment for women to enhance fertility, prior to an orthopedic intervention, prior to being on the list for cardiac transplant. You have to have a BMI less than 35, prior to a kidney transplant, prior to any surgery that will have increased risk of complications if the patient doesn't relieve the fat tissue and its effects on the organs. Anti-obesity agents give you 3 to 17% weight loss. As I already told you, the band up to 23%, but that weight is regained after a while because you're just putting a restriction and not changing gut hormones. Add medications to the band, now we're talking. As I told you about that one patient, the gastric sleeve, 25 to 35%, the bypass, up to 38% and more. But diet, exercise, and behavior is important for all of the modalities. Why? Because the surgery and the drugs help you stay on diet and exercise. That's what it does. It helps you stay on the program. It's drugs and surgery are adjuncts to lifestyle intervention. Alone, you're going to get improved metabolic control with lifestyle and quality of life. What are the components of lifestyle? Nutrition, physical activity, and healthy behavioral habits, limiting alcohol, getting enough sleep, because if you don't get enough sleep, your hunger hormones are revved up, and stress reduction as well. The components are a reduced calorie meal plan, more physical activity, and behavioral intervention. Okay. All right. How do you intensify lifestyle? In the doctor's office, you're going to get some advice. You can use the internet or self-help.
The last 17 years that I have been dealing with these patients, I think there is only one word that comes to my mind, that they need support in every way. It's not only in terms of treatment, it also means in terms of motivation, in terms of psychosocial support, in terms of everything else. And unlike common perception, they need a lot of family support as well. And I think the World Health Organization has already recognized obesity as a chronic progressive disease, which results from multiple environmental and genetic factors. Dr. Caroline has already gone through those factors, so I wouldn't be repeating them. But chronic progressive is something I think which you people understand a lot more than us surgeons. We are used to treating gallbladders and hernias, and none of that is chronic progressive. It's treated and done with. But obesity is chronic progressive, just like diabetes and hypertension and cancer and heart disease, and it needs prolonged treatment. And chronic illness is defined as a condition that lasts a year or more and requires ongoing medical attention. So whatever therapy we are trying to institute for our patient, whether it is diet and lifestyle modification, or it's pharmacotherapy, endoscopic therapy, or even bariatric surgery, I think once a patient is always your patient, and he or she is going to need ongoing medical attention for life. So my presentation will basically cover everything from pre-surgery consultation to myth busting to the long-term issues and how we do the post-operative follow-up and everything else. Now, I think one of the biggest parts about surgery is, as a physician, it would be very confusing to understand who would qualify for surgery. So, yes, we definitely have guidelines, and we have the Indian guidelines as well. We have the guidelines from Obesity and Metabolic Surgery Society of India. And according to these guidelines, anybody with a BMI more than 35, with or without any presence of comorbidities, would be eligible for a surgical option. Anyone with a BMI more than 30 in the presence of 2 or more obesity-related comorbidities, especially diabetes, would definitely be eligible for surgery. BMI more than 27.5 with uncontrolled diabetes, despite optimum medical management. So this is a very rare scenario where usually patients would be on medical management and they have already kind of saturated everything, and then they are referred for surgery primarily for diabetes management. Waist circumference again is a very important aspect for us, especially in this part of the world, in the Asian region, in the Asian context. It becomes very important because we all know that it's a visceral fat which is actually responsible for all the metabolic effects of obesity. And waist circumference more than 80 centimeters in females and more than 90 centimeters in males, along with type 2 diabetes, is again an indication for surgery. When it comes to age criteria, the age criteria can be flexible, but generally, according to guidelines, it's the youngest that we can operate is 18 years of age. Of course, there are reports and there are cases where adolescents or even children younger than 18 years of age have been operated upon, basis the clinical urgency at that time. And anybody up to 65 years of age is definitely eligible, but we see many patients who are more than 65 years of age and they are medically fit for surgery, and if the surgery can improve their quality of life, then they can be eligible candidates for surgery. One requirement is that any patient who is advised bariatric or metabolic surgery must understand and must be motivated to enter a long-term weight management program and should be committed for lifelong follow-up. This is something which we need to grill into our patients at the time of pre-surgery consults as well. And it's the responsibility of the pediatric team as well to provide a long-term weight management program and follow-up protocol. Now, these are certain contraindications or situations where we may not consider surgery for a patient. So anybody who is upfront and says to us that they would be unable to take nutritional supplements or they are averse to taking nutritional supplements wouldn't be a good candidate for bariatric surgery, because as we know that any procedure, whether it's a sleeve or a gastric bypass, we are changing the GI anatomy, and every surgery would have a potential for nutritional deficiencies. So if a patient is not willing to take nutrition supplements, then I think he or she is not a good candidate. Of course, anyone who's medically unfit should not be taken up for a surgery. Anyone with a non-stabilized psychiatric disorder, again, is not a good candidate. Anyone who's a chronic smoker, chronic alcoholic, or has drug dependencies, unless they have been through a de-addiction program successfully. So the first step would be to help them to de-addict and then probably consider surgery for them. Anyone with, say, a metastatic cancer or a shorter life expectancy due to any kind of terminal illness, and of course, pregnant women are not eligible for bariatric surgery. Now, recently, in the last year, we've had the newer guidelines which have come from the American Society of Metabolic and Bariatric Surgery in association with the International Federation for the Surgery of Obesity and Metabolic Disorders. So if you all may know that the guidelines that were being used internationally were the NIH guidelines from 1991, and we are in 2023 now, so it's almost been 3 decades, and those guidelines needed revision, and they have been revised last year, and the BMI cutoff has been reduced for bariatric surgery from 40, which was in the Western countries, to 35 now. So anybody with a BMI of 35, regardless of presence or absence of any comorbidity, would be eligible for bariatric surgery in the Western world as well now. And with comorbidities, it is now between 30 and 35. And for the Asian population, these BMI cutoffs would be 2.5 points lower. So what was 35 for us will now become 32.5, and 27.5 would again be eligible for surgery, which may be a gray zone where, you know, drugs can also be used and surgery can also be used, and we'll see how it all shapes up in future. And of course, I mean, long-term results of metabolic and bariatric surgery have consistently demonstrated safety and efficacy, and appropriately selected children and adolescents should also be considered for metabolic and bariatric surgery as per the new guidelines. So this was about the eligibility for surgery, but we don't always strictly follow the guidelines when we are treating our patients, and we actually look at many other things while we are taking a decision for a surgery or any kind of treatment plan. And it is important to know who we are treating. I think obesity is a disease where it is important to look at the person as a whole and not just a BMI or a waist circumference. This is a disease where I see patients who come to us who are practically, who can be termed as disabled because they cannot walk, they can't even walk 2 steps, they cannot even, help themselves with a glass of water at home. This is the kind of image which we see quite frequently during surgery. I mean, these are livers which are very nodular, almost bordering on to cirrhosis, severe NASH, and usually not picked up by routine investigations because of the fat, the subcutaneous fat in the patients with obesity. So the disease is actually affecting them chronically and progressively without, being very visible from outside. It is just like diabetes. So how the way diabetes is causing all these chronic issues and leading to a lot of other problems with almost every organ in the body, same is the case with obesity. These are the kind of lower limbs that we see very, very frequently with in our patients. This is the amount of fat. It's like a sea of fat when we go into these abdomens through laparoscopy. Lot of non-healing ulcers, and like I said, I mean, some of these patients are not able to walk, they're not able to do anything on their own, they're dependent on their family members for almost everything. And it is kind of our job to, help them and safely take them through any kind of treatment plan that we are advising for them. So this is in general, sorry, it's a little busy slide, but this is the amount of evaluation that is needed. This is just the history and examination and the entire diet protocol, diet recall, and everything that we have to take before during our assessment for bariatric surgery. But some of the key points that we would really want to know is about our patient is what was their highest weight and what was their lowest weight. So lowest weight in their adult life tells us basically the point from where they started gaining weight. What is the age of the patient? So age is again a very big deciding factor, especially for me, because if the patient is a senior citizen, I cannot expect a 65-year-old lady to go and work out in the gym and work on strength training and things like that. This is a lady who's been advised knee replacement by the orthopedic surgeon. How is she going to lose weight? Or what are the attempts at weight loss? I mean, the common perception is that people are not doing anything and they're kind of lazy. But unfortunately, and what I see normally is that these are patients who have done everything on the earth. They have tried every diet program. They have been there, done that. And it's important to know the struggle behind their story and why they have finally resorted to an option, a surgical option. When did the weight start increasing is again very important. Has it been a gradual weight gain? Has there been any life event like an accident or any place where they needed to start taking steroids, or did they get bedridden at any point in time? Any situation which probably may have led to weight gain. Drug history again is very important, because there are many drugs which you know better than me that can lead to weight gain. Psychosocial history again is very important. So how has this patient been affected? I mean, the patient, there are so many of them who lose their jobs because they just can't work. They can't even move. So how can we expect them to actually go to work? And unless they lose weight, I mean, they really can't do much in life. What is the present quality of life? I think that is one of the most important questions, that what kind of a life is this patient leading with this weight? So quality of life is very, very important. It is, I mean, it's really moving to hear their stories about how they lose their jobs, how they're not able to do anything, how they're ostracized by the society, by their own family members. And, you know, parents come with younger children and they feel that the children are not doing anything, because nobody understands the pathophysiology of obesity. And everybody just feels that these are people who are not taking enough effort to lose that kind of weight. And how many medical admissions have they had? It's amazingly, it's surprising to see the number of medical admissions that they need because of weight-related issues. And unfortunately, we see many patients who come for consults, then they would probably wait. And because, like Dr. Caroline mentioned, that acceptability for medication itself is so low. So you can imagine how it would be for a surgical treatment option. So the acceptability is still very, very low. And we have less than 1% of patients who actually undergo bariatric surgery despite being eligible. And these are patients who go back, they are kind of told by the society or by their family members to keep trying in the natural way. And unfortunately, a lot of times they have events, medical events like, I mean, they would have cardiac failure, or they would have any other issues which can lead to multiple medical admissions, and eventually they may actually become unfit for surgery as well. Now, these are the standard bariatric operations which are being practiced across the world today. Out of these, the sleeve gastrectomy and the Roux-en-Y gastric bypass are probably the commonest procedures which are being done. Sleeve gastrectomy even more common than gastric bypass, probably because it's easier, it's more physiological, and leads to lesser nutritional deficiencies as compared to a Roux-en-Y gastric bypass. This procedure here is the gastric banding. At least in India, it is completely out of fashion. We don't do this anymore here because the results were not very good. So last 15 years or so, the band is not being performed in the country. This is the single anastomosis gastric bypass, an upcoming procedure which is becoming quite popular with the surgeons as well as patients, with decently good results and a little bit easier to perform as compared to the Roux-en-Y gastric bypass. Then we have the laparoscopic duodenal switch, which is a very malabsorptive surgery, not very commonly performed in our country because I don't think our patients can nutritionally cope up with something as malabsorptive as this. And this is a procedure which we would consider only as a revision procedure, even that very, very selectively. So these are the two main procedures. Talking about mechanisms, I think all the surgeries lead to restriction in reduction in the size of the stomach. So definitely the caloric intake goes down. The amount of food that a person can take goes down considerably, and they feel full very early. So early satiety is one of the biggest factors. Third thing is that the ghrelin hormone levels go down, reducing the amount of hunger that a person can feel. So though despite they're eating less, they're not hungry, they're not craving for food. And of course, the biggest hormonal change that surgery brings is an increased GLP level. So GLP-1, PYY and GIP levels increase very considerably after any kind of bariatric surgery, including a sleeve gastrectomy as well. So these are the main mechanisms by which surgery acts. These are certain newer procedures. We call them the sleeve plus procedures. They are a little bit more complicated, but being performed selectively for a few patients. Now, how do we select which procedure for whom? A lot of patients would come and ask you that, should I have a sleeve or should I have a gastric bypass? I'm feeling a little bit confused. What should I do? So I have here a comparative chart which tells us about, so the excess weight loss, if you see, is sleeve would have about 65 to 75%, and the gastric bypass would have about 70 to 80%. Remission or improvement of comorbidities, I'm sorry to use the word resolution, it should be improvement, is good in sleeve. It's definitely better with any kind of bypass. Complications, of course, are a part of any kind of surgical procedure. In fact, any kind of treatment has complications, including medications as well. But yes, surgical complications can be a lot more severe. So sleeve has complications like leaks or acid reflux and Barrett's esophagus in certain cases. In a gastric bypass, of course, leaks can be there, but we can also have marginal ulcers or internal herniation in the long term. Learning curve for a sleeve is much shorter for the surgeon per se. It is much longer for a Roux-en-Y gastric bypass as compared to a sleeve, and hence, the popularity of sleeve is not very surprising. Nutritional deficiencies, definitely, because sleeve is a more physiological procedure. We are not bypassing the gut, so nutritional deficiencies are lesser in a sleeve as compared to a bypass. And a sleeve would be contraindicated for anybody with GERD or hiatus hernia. So in my mind, any patient with hiatus hernia is definitely not a candidate for a sleeve gastrectomy. So that is one of the most major deciding factors for us when we decide about the procedures. And Roux-en-Y gastric bypass actually would be the treatment of choice for a patient with hiatus hernia and GERD. Now, weight regain, like we all know, is the biggest bane of any treatment for obesity. And after a sleeve, we see more weight regain as compared to a gastric bypass. When we talk about weight regain, we also talk about revision surgery. And the options for revision are much more after a sleeve gastrectomy as compared to a gastric bypass. Now, sleeve is also endoscopically accessible to us, unlike a gastric bypass, where we are bypassing the stomach and hence we cannot access it within endoscopy. So in countries like Korea, where gastric cancer is very common, sleeve gastrectomy is the preferred procedure because it would always be available for surveillance. And of course, when we talk about reversibility, a sleeve would be irreversible because we're removing a part of the stomach, whereas technically a gastric bypass is a reversible procedure. So if we see over here, as the weight loss increases, with increasing weight loss, we get increasing improvement in comorbidities, but we also get increase in nutritional deficiencies. So sleeve has the least amount of nutritional deficiencies, and the duodenal switch and the one anastomosis gastric bypass would have a lot more nutritional deficiencies. So after all this, I think during consults, one of the major concerns that patients have are regarding the myths about bariatric surgery and these weight loss treatments. One of the biggest one which I hear is from patients when they come and tell us that surgery is an unnatural way of losing weight. Everybody's family wants them to lose it the natural way. They want them to just stick to diet and lifestyle modification, or go to the gym, or take a crash diet and just try to lose weight by that. And I think we need to remember here that every disease has a grading and a staging, including obesity. Maybe it's not as formalized as cancer as yet, but we have to treat the disease as per its stage. We cannot treat stage 4 with diet and lifestyle modification, and neither can we treat stage 1 with surgery. So this is what we need to inform our patients. They also feel that after bariatric surgery, they will never be able to enjoy food again, which is again a myth, because most of our patients are actually able to eat quite normally within a year or year and a half. They're able to cherish most kinds of foods. Of course, there has to be moderation in diet. A lot of them think that they will become weak, and the answer to that is that follow-up is the key to good long-term outcomes, and nutritional supplementation is a must. Without that, definitely there will be some weakness. So they need to be counseled about this before undergoing for surgery. A lot of people feel that they're going to die during surgery, and I think surgery has evolved a lot more. We are in 2023 and things have become much safer. The mortality after bariatric surgery is very, very low. They also feel that they will probably vomit after eating anything, and they tend to have these conversations with people who've undergone surgery. And these patients need to be counseled very well before undergoing surgery about the quantity of food, the measures that they can take, and how they should be eating. And that is done by a team of dietitians. A lot of patients think that they might become thin immediately after surgery. So when they come out of the theater, they would probably look like 50 kgs lesser, which is again something that they need to be counseled about, that it's a long process. It takes about a year. Hair fall is one of the important aspects. They feel that hair fall will be like chemotherapy, which is not the case. Yes, there is thinning of hair during the active weight loss phase between 3 to 8 months, but then it does come back, and usually by the end of 1 year they have their hair back. A lot of people feel that they will look very old and haggard, and we still are kind of trying to bust the myth that bariatric surgery is not plastic surgery, it's not cosmetic, it's not liposuction. And again, the last one, that it may lead to impotency or infertility. In fact, I think bariatric surgery is done on a lot of patients with infertility to help them to deal with infertility and to conceive. And it works really well. So these are the available treatment options, which is these four mainly. So you have diet and lifestyle modification, drug therapy, endoscopic intervention, and bariatric surgery. But what we need to explain to our patients is that monotherapy may not work for every patient. We need to see what stage of the disease the patient is at. If a patient is, say, 75 kilos, definitely diet and lifestyle modification will probably work alone. But at 90 kgs, he may need diet and lifestyle modification with drug therapy. And escalation of therapy may be needed. If the person is already 140 kilos, then bariatric surgery would probably be the option to go in for. And we need combination therapy. There cannot be one thing which will, bariatric surgery alone cannot treat the entire disease, right? So this will need to be bariatric surgery plus diet and lifestyle modification. I may need to use drugs as well after bariatric surgery for weight maintenance. And there has to be titration as per response to treatment. So exactly like diabetes. So when the HbA1c increases, we increase the intensity of the treatment. And if everything is under control, we can bring the intensity of treatment back to what it was. So titration has to be done as per response to treatment. There is no one-time treatment for obesity. And like I have been emphasizing, the treatment is going to be lifelong. When a patient is coming for surgery, I think it is very important to set the right expectations, because we need to educate our patients about what they're getting into. And terminologies that need to go away from our vocabulary are cure. Nothing can cure obesity as of now. I think we are very far away from that. It is a very, very complex disease. And I know this is a very exciting time to be in this field. A lot of treatment, a lot of innovation is happening, and I think it makes us all feel very empowered. But cure is not a word that can be in our dictionary at the moment. Failure is again a term which should go away from our vocabulary, because weight regain is not failure of treatment. Sometimes the disease can be a lot more powerful, and I mean, we see it all the time in diabetes and hypertension and cardiac disease, that sometimes everybody may be doing everything right, the doctor is doing everything right, the patient is doing everything right, and yet the disease progresses. So it cannot be termed as failure. There is no ideal treatment. There is no one treatment, there is no gold standard treatment, and there are no undesirable results per se. Terminologies that we need to include when we are managing obesity is that it is a chronic progressive condition. This is something that we need to educate our patients about. Whatever we do, we are trying to put the disease into remission or control. We may need adjuvant therapy. it is not as formalized as it is in cancer, because there's surgery, chemotherapy, radiation, everything has to go hand in hand depending upon what kind of cancer it is. Same is going to be the case with obesity in future, where probably pharmacotherapy or endoscopic therapy or some combination of bariatric surgery may be needed. Hence, the treatment has to be comprehensive. Compliance is the biggest word that is, I think, needed for any chronic progressive disease. If our patients are not compliant, or if we are not able to develop tools to make compliance easy for them, I think we will find it very, very challenging to treat these patients. Support is the next word. I started my presentation with support, and I think that is one of the main pillars of treatment. We need to look at treatment outcomes in terms of 5-year outcomes. One treatment cannot last for a lifetime. In cancer also you have 5-year outcomes, and we need to acknowledge that these are diseases which will have recurrence, which will have some degree of regain, and that will need to be dealt with eventually. And care has to be bidirectional, like in any other chronic disease. It cannot be only the doctor's job to treat these patients. The onus also has to be on the patient. And in fact, I think we need a whole village to treat patients with obesity. When we talk about pre-operative investigation, there is a whole comprehensive list. But like I said, the two main procedures, sleeve and bypass and upper GI endoscopy, along with clinical symptoms and signs, would be one of the most deciding factors for choosing a bariatric procedure. One other factor which we need to take into consideration is also patient's wish. What is the procedure that patient wants to have? Because we cannot ignore the fact that our patients today are very educated and they do a lot of research before coming in. So it is important for us to take their wish into account and have a mutual discussion, guide them about the pros and cons, and then take a decision. Pre-surgery preparation is, these are the basically the goals. So there is a pre-surgery diet, and we do focus on pre-surgery weight loss, which is mainly to improve the liver health and to decrease the visceral fat so that it makes the surgery easy. A lot of importance is laid on treatment of nutritional deficiencies, because unlike common perception, obesity is also a state of malnutrition, and we see a large number of nutritional deficiencies like vitamin D3, vitamin B12, iron deficiency, calcium, folic acid, and so on. So these have to be treated well before in time, before we take the patient on table. Unlike other surgeries where, you see the patient one day and operate the next day, it doesn't go like that for bariatric surgery. Patients, of course, need to have their fitness consultations. And one important aspect is to treat them for sleep apnea, because that is very important. It really has a lot of bearing on our post-operative outcomes, and teach them breathing exercises, etc. So the whole goal of optimization is that the better we optimize, the better are the post-operative outcomes, and lesser are the chances of complications later. This is a whole range of comorbidities that improve after bariatric surgery, which is very dependent on weight loss. And as our patients lose weight, I think everything improves, including their metabolic syndrome, which is almost 80% improved. Diabetes, hypertension, risk of heart disease, everything goes down. We see a lot of improvement in infertility as well. GERD, if the right procedure is done, a lot of improvement in polycystic ovarian disease. There is 89% reduction in overall mortality, and most patients actually experience a very marked improvement in quality of life after weight loss. Complication, of course, nobody likes them and nobody wants to have them. But as a surgeon, I would be lying if I say that there are no complications at all. So yes, complications can happen. They can happen after any surgery. We need to inform our patients before, during our counseling, that what are the common complications. But the overall risk of complications is less than 2%. I think it's much lesser than that. This includes minor and major complications. The risk of major complications would be much lesser than that. Today we have much better technology. We have a lot more experience now with bariatric surgery, and I think surgery has been around for more than half a century now. And laparoscopy has definitely made it better. And we also have more experience in managing complications now. So it is not very common for us to have a mortality after bariatric surgery anymore. So when patients come asking about complications, I think that is one of the biggest things that they really want to be clear about. So we need to, I think, guide them about two things that I always tell them, that you have to see it with a different perspective. First, you need to realize that what are you dealing with? What is the disease? How much obesity you have? And in the long term, what are the complications that are expected because of this weight? And what would be your life expectancy? And then you have to see what are the complications of surgery. Is the risk worth taking? So if the pros and cons have to be weighed properly before going in for surgery, but we need to give them that bird's eye view about all the problems that can happen because of their weight as well. So it is, when we talk about post-operative care, this is all about pre-op consultation. I just have about a couple of slides more. I think post-operative care, it's very important to keep the goal in sight. So definitely good weight loss is what we are aiming at. But along with improvement in comorbidities, we also want our patients to become better in terms of their glycemic control, in terms of their hypertension, the cardiac risk, and everything else. But we also don't want to harm our patients in the sense that we want to prevent all kinds of nutritional deficiencies, and hence importance of follow-up is very, very high in bariatric surgery. We must keep addressing their common concerns through support group meetings, through one-on-one consultations, and today we have technology to reach out to our patients at the touch of a screen. And one thing which we have to focus on is basically good quality of life. So it's not about just chasing weight loss. There would be patients who would be happy with 20 kgs weight loss and they're happy to move around and do their things independently. And of course, goals are different for each patient. So obesity management is beyond bariatric surgery alone. It's not just about surgery. So we need to have a very stringent follow-up. We need to have repeated counseling sessions, because surgery is a one-time thing. But to be able to maintain the weight loss, to be able to avoid any kind of deficiencies, to become more fit, to become more disciplined, and to be able to give them tools to be compliant, I think repeated counseling sessions are very important in the post-operative care. And that is where I think our physician colleagues are very important, because the patients are definitely more comfortable with their physicians, and they can become a big part of this. And they need a lot of motivation for sustained lifestyle modification. And we need to keep doing things and keep giving them tricks and techniques to increase compliance, not only for supplementation, but also for lifestyle modification. And willingness to seek help. So I've had patients who've not come to us because they have regained weight, because they feel that we will get upset with them, that why have they regained weight, again implying that it is their responsibility alone to maintain their weight loss. So we have to tell them that yes, this is natural progression of the disease, and this will happen. When this happens, you need to come and seek help again. So goal of bariatric surgery is definitely not just to lose weight or to chase any number of weight loss or any percentage or 30%, 40%, but it is basically to prevent future obesity related complications and to provide a better quality of life to our patients. These are just a few patients. I think I am very happy with results of bariatric surgery, especially in our older patients, because it really changes their life. And one of the biggest things that they appreciate in life after losing weight at that age is independence. These are women who are 65 plus and they had surgery, and initially they couldn't get out of the house, and today 3, 4, 5 years later, it's hard to keep them back in the house. It also works very well in patients with disability. So this is a lady who had polio, and she was completely immobile. Because of the weight, she couldn't even use the crutches. And now after surgery, of course, now she's much thinner and much lighter even than she is in this picture. These are some other patients. So last slide, surgery is also now covered under insurance in India. It's been a very big step for us and for our patients because the cost was one of the biggest barriers to seeking help with surgery. And now almost every insurance company is covering it. Of course, they're following the age-old NIH criteria of BMI more than 40, but something is better than nothing for our patients. So in the end, I would just like to say that a lot is happening in this field. We have newer treatments coming up, we have newer drugs coming up, and that makes us feel very empowered. But again, the problem is not about having the treatment available. That was one aspect of it, but it is also about taking it to the right, the needy patients. And we also need to set the right expectations when it comes about surgery. So surgery is not a shortcut. It's not an easy way out. It's one of the hardest things to do for any person. And surgery is not the end. It's the beginning of their weight loss journey. Obesity is a chronic disease and it needs to be treated like one. We need to probably borrow tips and tricks from our diabetes and cardiac colleagues. And sometimes we may be doing everything right, but the disease may be too aggressive and we really can't do much about it at that time, but we have to keep trying. And obesity is in a very nascent stage even today. It is an evolving science and we are learning every day, and hopefully we will be able to do better by our patients in the future. So thank you very much, and I will stop sharing my screen now. Thanks a lot.
Thank you, Aparna. I think it was an excellent lecture and a lot of take-home points for everybody, particularly people who are looking at patients who have been, post-bariatric surgery. And I'm sure there are a lot of difficulties that they face. I want to open up the platform, for a panel discussion. I want to introduce Dr. Neeta Deshpande, who is a bariatric physician at the city of Belgaum. She's done immense amount of work in the field of obesity, and nobody better than her to conduct the panel discussion. I would also like to take the opportunity to introduce Dr. Guillermo Umpiras. He's the chairman of Idec and the president of the ADA. And it's wonderful to have you with us, Guillermo, and look forward to a very active participation. We have Dr. Caroline Apuvian. She's from the Brighams, and she's been our guest star today, and excellent lecture that she delivered. So look forward to a great interaction ahead, and over to you, Neeta.
Yeah. Thank you, Sanjay. And I welcome everyone once again, especially those people who joined in late. And we will now launch into the panel discussion, the question and answer session. And the very first question is from one of our very own IDEC members, Dr. Nitin Kapoor, who's here. But I'm going to read the question that he's posted in the chat box. And this is for Professor Caroline. He asks that, now that we're using body composition more than ever before in clinical practice, we find a large number of patients with sarcopenic obesity in our practice. So in addition to ensuring adequate protein intake and resistance exercises, what other tips or medications would you suggest that can help manage these patients?
Wow, that's a great question, Dr. Kapoor. First of all, while it's true that we have better techniques for measuring body composition, it's still true that the cheapest way and most easiest way of doing of checking for obesity is still the BMI. So many people will not be able to check body composition. Having said that, we know that after bariatric surgery and in older patients, we know we're going to get a lot of muscle loss, especially if those patients don't do resistance exercise training and eat more protein. How much is more protein? 1.5 to 2 grams per kilogram of body weight. Most people don't get this kind of protein intake after bariatric surgery and in the elderly. So there are more ways of enhancing body composition. If the patient does have low testosterone levels and is a male, they have to have low testosterone levels, but a little bit of testosterone replacement might help. We're looking into, it's still research, but growth hormone, still in research studies, not ready for prime time yet. And then there are, for women, hormone replacement therapy is now considered important. The WHO study, was a flawed study that put hormone replacement in patients who already had heart disease, age 65. That's too late. That's why it showed an increased rate of cardiovascular events. We now know that it was a flawed study, and we now have our up-to-date women's health providers prescribing hormone replacement therapy for women in perimenopause. I urge everyone to look at the literature now and prescribe when necessary. Hormone replacement for women include resistance exercise and higher protein. Same is true for men. Plus, consider testosterone. And in the future, we should have agents that increase muscle mass and help fat loss. One is in studies currently and has been and is ready for prime time in the next few years. But that's what I would recommend now is increase protein, resistance exercise, and consider anabolic agents.
Right. So there is one question that I would like to ask Dr. Aparna, and that is that in the population that needs bariatric surgery, people with morbid obesity with BMIs upwards of 40, and those who can afford it, there is a huge resistance to it as yet in India, despite the fact that they have tried and failed so many times at different kinds of weight management. So what, in your opinion, in a country like India where bariatric surgery is still not taken off to the extent that it should, what, in your opinion, is the way that we go about educating the public about bariatric surgery? I know you've covered a few myths and in your lecture, but in general, in short, could you tell us how we could do this?
I think, Dr. Deshpande, one of the things which probably, I think the first barrier is that people don't look at it as a disease. That is number one. They still view it as, even today, I think in our country, these are people who would be considered as coming from a, affluent family and having enough food on table and things like that. Second thing is that people are not aware about the progression of the disease, what it can lead to. So even today, like I mentioned in my talk, that we see patients who come, then they don't get treated. Then there is an event which pushes them into surgery. And then when we evaluate, we see that the ejection fraction has gone down to 20% and they've missed the bus. So they don't know that this is how dangerous it can be, for many, many people. And or how it can affect their knees, how it can lead to cirrhosis of liver. Today, obesity is one of the biggest causes for cirrhosis after, it's said to have overtaken alcohol as a cause of cirrhosis. So people are not aware about that. And I think we need to educate them about the sequelae of obesity, just like we've made them aware about the sequelae of diabetes. And that is what has kind of, given a seriousness to that disease. So that is where we need to start working. And that would be one of the other things. Cost was definitely one of the barriers for surgery as well. And I think probably with insurance coming in, that barrier would be broken to some extent. But any surgery, including a surgery for gallstone, I think including cancer, we've seen people going for alternative therapies and things like that. They don't want to get operated because there is a certain kind of stigma and fear attached with surgery. So that is bound to be there. But there is a lot of work which we need to do, I think.
Right. Thank you for that. So there is a question here from Dr. Suresh Shinde from Pune, who is an avid researcher himself. And the question is to Dr. Caroline, which says, does semaglutide have any peripheral lipolytic action in addition to its central anorectic action?
No, there is no peripheral lipolytic action of semaglutide. We are looking into its action as in decreasing the metabolic gap that occurs with weight loss, and that metabolic gap may be restored by hormonal activity that is dampened by loss of leptin. So we don't think that GLP-1s are working by directly increasing brown fat activity. If that's what I think the questioner is asking about, but we think it does have another augmentation of energy expenditure by increasing the metabolic gap that is reduced by lack of leptin.
Right. So Dr. Guillermo has a question.
So Carolyn, thanks for participating with the IDEC.
Yes, great to see you.
So hard to have an intake greater than 1.5 to 2 grams of protein a day. I mean, I'm in the 60s, and my wife told me that I needed to eat 1 gram of per kilo per day, and I can't eat 80, 100, or 75 grams of proteins a day. How do you do it?
That's a great question. So what I recommend to my patients is a protein shake. And the best time, so in older patients and even younger patients, the best way to replace muscle loss is not just at one meal. So most people eat most of their protein at dinner. That's not going to work because the muscle needs the amino acids during injury and in between meals as well. And so what I recommend to patients is to take in protein at each meal. So that would mean in the morning, yogurt and milk and eggs, or a protein shake. Now, your protein shake, typically, if you make it yourself, you're going to get a whey casein powder that's going to give you 20 grams of protein per shake. All right. So you're going to mix that with milk and some berries to make it taste good. Now, that's going to be, if you can't do that because it's so many calories, that can give you, if you take it twice a day, it's going to give you an extra 40 grams of protein. If you can't do that, then there are powders that there's one called Juven, Juven, that you can get on Amazon. That is a powder that you mix with water, and it's amino acids. And the amino acids are all the essentials plus extra leucine and arginine. And it has been shown that if you use it right after, physical activity, like, you ran or whatever, it's going to go right to the muscle to replenish those amino acids and help wound healing and muscle accretion. Juven, it was used in the hospital for older people, but I can tell you that the Patriots are using it for their football players to enhance muscle, anabolism in between their, practices. So I hope that's helpful.
Yeah, very much. Thank you.
Yeah, sure. Juven is the...
That was really an interesting question, and we all grapple with that, with protein intake. So thanks for that question, and thanks for the answer as well. So there is one question. Sanjay has asked this question, and this is for Dr. Aparna. Post-bariatric surgery, when there is weight regain, when do you decide to introduce either a GLP-1 receptor agonist or revision surgery, or do you do both?
So this is a very gray area where I think it's completely as per the clinical discretion. There is no guideline for us today to decide that at what juncture would I start using a drug or where would I institute a revision surgery. But I can say one thing with confidence, that with incoming drugs, even though we don't have injectable semaglutide as yet in our country, pharmacotherapy has definitely decreased the rates of revision surgery even in India, even with just having liraglutide, because we've seen that it works pretty well with post-surgery weight regain. And my guideline to my patients is that whatever is the nadir weight that you have achieved, the lowest weight that you got to, if you feel that there is an increasing trend and you have regained 5 kgs from there, please come back to us, because we will need to see what is going wrong. Of course, I mean, it could be just the natural progression, or sometimes they deviate from their, lifestyle, and something happens and they stop going to the gym, exercising. So we try to motivate them. But if the trend is increasing, we wouldn't allow the weight gain to go up beyond 5-7 kilos. We would institute the drug there, because it's much easier for us to handle a 5-7 kgs of weight regain as compared to a 10 to 15 kgs of weight regain. But yes, of course, there are patients who've been operated 10 to 15 years back. Some of them have come back with significant amount of weight regain, and they've come back by 30-40 kgs of weight regain. Then probably a revision surgery would be an option. But even there, we would use pharmacotherapy as a first line of therapy and see where they get to. If they are showing a decreasing trend and if they're doing well, we've had patients losing 15 to 20 kgs even on liraglutide. And if they do that, then we don't really need to do a revision in that patient. But then we do guide them that pharmacotherapy is something that may be needed again as well. So once they come to the target, we stop, we just maintain on diet and lifestyle modification. If the weight regain happens again, then we may again need to institute the drug therapy. So this is something where I think it's completely on our clinical discretion. We don't really have any guidelines at the moment for this.
Right. So that's a very nice answer. Thank you for that. Then another question about, again, a GLP-1 receptor agonist from Dr. Suresh Shinde, and this is to Dr. Caroline. He says, GLP-1 is basically a prandial hormone. What happens physiologically when we give it during the fasting state, when there is no glucose coming from the gut?
A great question. So yes, it is a postprandial hormone. It only works, however, to increase insulin from the pancreas when glucose levels are high. And Guillermo, please correct me if I'm not saying something, quite right, but it only works as a hypoglycemic agent when glucose levels are high. So it's not going to cause hypoglycemia during the fasting state. Having said that, however, we should be careful when patients use it post-bariatric surgery. Why? Because some of those patients do have late post-bariatric hypoglycemia, and we don't want to use it in that case, even if a patient needs to lose weight, because that hasn't been studied. But having said that, in the fasting state, what it's going to do is still going to have its peripheral effects on delaying gastric emptying and gastric motility, and it's still going to have its effects on satiety, because the GLP receptors are also in the brain.
Right. So I think since time is running out, we will have one last question from Dr. Anjali. She's raised her hand. So Anjali, you can ask your question now.
First of all, I would like to thank Aparna Di for coming and joining. She's a very dear friend. We know each other for more than a decade now, even probably more than that. Studied together, had a very wonderful journey together. So, Dr. Aparna, I have a question. I'm seeing a couple of patients who are now pregnant after their bariatric surgery. The micronutrient recommendations, are they different in pregnancy compared to non-pregnant people?
You
did.
So pregnancy is recommended after about 18 months of bariatric surgery. That is a time when they start eating better and they're able to take a lot more food than they would in the beginning of surgery. And what we normally do is that we would just do a check at that time to assess what is the nutritional deficiency status and supplement as per the deficiency state. We don't really supplement them extra apart from the normal folic acid and stuff like that. But there is no additional supplementation which is needed just because of surgery.
Sure. Thank you.
Thank you so much. And we've had a wonderful session. There's been a fantastic panel discussion. And I thank both the speakers, all the delegates who have joined in and been very interactive. And at the end, I would just like Dr. Sanjay to give concluding remarks before we sign off.
Thank you very much, Dr. Caroline, for accepting our invitation to speak today. It's been a wonderful lecture, and I think all our attendees have been privileged to hear your thoughts on, on the subject. You have been a pioneer in obesity, and obviously your recommendations go a long way, and it obviously clears a lot of doubts for all of us. Dr. Aparna.
I just want to say something about Dr. Aparna's talk. It was wonderful. Dr. Aparna, you gave a better talk than most of what I've heard in bariatric surgery talk. So excellent job.
Thank you so much, Dr. Caroline. And I am also very educated about the drug after your talk. So thank you so much. Thank you.
Thank you, Aparna, for being here. And I think the greatest compliment comes from Dr. Caroline, and I think it's a very, very big compliment. And pleasure to have you with us. And we look forward to have both of you again. And Dr. Caroline, we look forward to invite you to India for sure during one of our meetings, and hope to see you soon in India. So with this, we'll sign off, and I would like to thank all the delegates for joining up and listening to this wonderful interaction on obesity. And from IDEC, we promise to bring you more science in future. So look out in the space for more scientific talks to come. And thank you the entire IDEC team who worked round the clock at the back end to make all this possible, a seamless presentation. So thank you, all of you, and good night. Thanks once again.
Thank you, Anjali. Bye.
Pleasure, Di. Bye-bye.
Bye.